welcome everyone to AAST Grand Rounds. We apologize, we had a little technical difficulty, so we're starting just a few minutes late. My name is David Notrika, and I'm a pediatric trauma director at Phoenix Children's Hospital. Our panelists today include Jessica Nadich, who is at Dell Children's in Austin, Dr. Ward Richardson, who is the trauma medical director also at Pittsburgh at UPMC. No, Pittsburgh Children's, right? And am I saying it wrong? Tell me out.
Children's Hospital Pittsburgh of UPMC.
Yeah, that. And then Katie Russell is trauma surgeon and trauma medical director, I believe, at in Salt Lake City at Intermountain Primary Children's Hospital. Chris Newton is vice chair of the AAST Pediatric Surgery of Trauma Committee, and is at UCSF in San Francisco, that's it. Dr. Jamshidi, who is also going to join us, got laryngitis and literally has no voice at all. So luckily we have some extra cases, so we should be okay. I think we will, a couple of things, and that is that the questions for the audience will be typed, they won't be verbal, per the AAST guidelines. And then we're going to start with Dr. Jessica Nadich, who's going to share her screen, and we'll present the cases, and then the experts on the hot seat will be asked to help us tell us how they manage this. All right, so you can unmute Dr. Nadich whenever you're ready.
Got it. Jeez. All right. Thanks, everybody. You can see my slides, yeah?
Oh, yeah.
All right. Nothing to disclose. All right. So here's the case. EMS calls with an 8-year-old girl who's in a motor vehicle collision, reported to be at 65 miles an hour into a dirt embankment. She was restrained in the back seat. A bystander had pulled her out of the car. EMS arrived, restrained her on a backboard with a cervical collar. They noted a heart rate anywhere from the 130s to 160s, and her GCS was depressed between 5 and 8. So the first question is, how do you prepare for patient arrival?
All right. Dr. Newton.
Well, I think with just minimal information, I'm at least worried about the depressed GCS and the tachycardia. So of course, that for our hospital triggers a full trauma. So for us, we have what's called full and partial. This would be our level 1, which brings everybody down, and maybe even tips off the neurosurgeon.
Okay. Dr. Richardson, anything to add in preparation?
No, I agree. I think if you have some heads up, I think what's nice is to have a team huddle, just assure that everyone who knows their role and responsibilities do a little debrief saying what's known about the patients, what you are worried about, just so everyone's on the same page. Make sure the OR is aware of it as well, potential operation.
Katie, you guys doing a pre-arrival timeout?
We are definitely a pre-arrival timeout. Then I would also make sure that we have blood available. We're a blood shortage in Utah. I don't know if everybody else is in the same position currently, but our packs are a little bit less robust than they usually are, but I'd make sure I've got my level 1 trauma blood, lab, x-ray, and let's take care of this kid.
All right, Nadich.
All right, so this was a primary survey. So she arrived, they were able to bag her with bag mask ventilation, but because of the depressed GCS, the decision was made pretty early on to get her intubated. While this process was going on, it was noted prior to intubation even that she did have decreased breath sounds on the right side, and her SATs were anywhere between the 50s and 90s, closer to the 90s, but every once in a while dipping down quite a bit. For her perfusion, she was said to be warm with 2+ pulses. Her heart rate initially was in the 140s. At one point did dip down to the 70s, and this was associated with a episode of hypertension about to the 180s, but mostly systolics were about 80, 90 with one dip to the 50s. In the trauma bay, her GCS was 8. Pupils were equal. And while they're examining her, they noticed there was an abrasion kind of in a seatbelt chest distribution, but a little lower. So maybe that chest strap was actually under her arm potentially. She had abdominal ecchymosis across a lap belt distribution that was higher than it should have been. She was distended. And then when they turned her, they could feel a step off at the upper lumbar spine.
Ooh.
So what now?
All right, Dr. Richardson.
So she, first of all, needs to be resuscitated. I had to give blood. Here, we certainly have a luxury of whole blood. I think she certainly would be reasonable to give whole blood.
Oh, just are you rubbing that in really?
It was a little bit.
Yes.
We felt the
Feel it.
dig. We
Feel the
felt
rub.
dig.
We feel the love.
Yeah, that was aimed at Utah. I can see
Okay.
it.
It was.
Certainly, you want to get a chest X-ray to see if the intubation is appropriate. If the breath sounds are still decreased, I think she needs a chest tube on that side as well, and see if she's a responder or non-responder up front.
Okay. All right. What'd you do?
So we got a chest X-ray, and you can see there she's got hemothorax on that right side. Maybe that diaphragm's a little high.
I think that the sonographer has a finger fracture too. I don't know.
Maybe it's very possible. And a fast exam was done where they thought they saw maybe a little free fluid in the pelvis, and that hemothorax was confirmed, but the pericardium looked good. Couldn't quite make out Morrison's pouch and the left upper quadrant appeared clean at the time. So I feel like we already talked about kind of next steps. So I'll give you that. So we did activate MTP. She got a liter crystalloid, and then we started MTP with blood. She did respond.
Oh, you gave her a liter of crystalloid. What does this child weigh?
She was eight years old. So I don't know, 40, 30 kilos, something like that.
Okay.
It's a lot of crystalloid. I agree.
Okay.
Yeah.
Okay, whole blood.
When did you start whole blood? This kid was in 2018.
We had it then, yeah.
Probably before then. We still don't have it. But MTP was activated. The level 1 was fired up to give rapid transfusion. TXA was given. Right chest tube was placed. Initially got out 600 cc's on placement. And then some labs were sent. Those didn't come back till later, but that's what they were at that point. What now? And really the question is, in my mind, are you going straight to the OR in this hypotensive tachycardic patient who has maybe a belly problem, maybe also a chest problem based on exam, based on chest X-ray? I do stop in CT first.
Katie?
We responded though, right? We responded to blood?
Transient, would get fluid or blood and would respond, but then would dip again.
And did we put a chest tube in? So we've got a chest tube in.
It's interesting because Hayden Stagg asked, are we going to put a chest tube in?
Chest tubes in, put out 600 cc's, and now it's about a liter actually. Now about a liter.
Why put it in after the chest X-ray? Why not put it in before the chest X-ray?
Well, I think you could, and it raises a good question. If you're doing a fast, anyway, do you believe you're fast in an 8-year-old in looking at the chest? And I think in our place, in my hands, I think that's great. I have an ultrasound probe. I have a stethoscope. That's all I need.
I would agree for a child who's, obviously looks like they're in hemorrhagic shock, has decreased breath sounds on the right side. Before you even intubate, most likely, you're going to have a chest tube in there. But they waited till after the chest X-ray.
Yeah, I agree. If especially the stats, you said were 50% to 90%.
Absolutely.
They weren't intubated at the time. If they came in intubated, I might see what the chest X-ray showed in case they were had a mainstem intubation, but somebody wasn't intubated and their stats were that low and you decrease breath sounds on that side, I probably would put a finger or tube in that side.
I have to agree. A lot of patients who have no breath sounds on the right that were intubated in the field may not be appropriately placed tubed.
Right. Right.
And then your question of to CT or to the OR, I love it, and I appreciate the question. If the whole blood has worked, okay, then now you have something to think about. So I guess I would turn it back to you, Jessica. Was this transient enough of a responder that you can get a film?
Let's say those present felt it was. And I guess my question is, let's say you went straight to the OR. What cavity are you going into?
Oh.
While you think about that, Barb Gaines texted, intubation can result in further hypotension. So just a little word of warning. All right, which cavity again, if you're going to the OR? Who wanted to go to the OR again?
I did.
I'm not sure anyone committed to that, but Jessica put us there.
Yes.
And I think
and maybe I'll just reiterate, as a transient responder, I think that's where you're going to with 600 cc's or a liter now out of a chest tube in an 8-year-old.
I agree in that scenario, but I think the important thing to note is pediatric trauma certainly can be different than adult trauma. If they do respond and stuff, you may not treat all, especially some of the solid organ injuries, the same way you would treat an adult. So I do think it's more of a thought process and impedes that decision-making pathway right there. Obviously, if they're just true transient responder, and then they're hypotensive again, you're going to take an unstable patient to the OR, not the scanner.
So let me make an argument for you and see if you agree with this. Put that X-ray back up again, Jessica. So we have an effusion, but on the right side, but we don't have a pneumothorax. So what you know is that you don't have a ripped or torn lung because you'd be leaking air. So if the most that you could have that hemothorax from is most likely going to be bleeding from the abdomen into the chest. So because there's nothing in the right chest, in this scenario, left chest, it could be the aorta torn, but in the right chest, there's just not that many things that can give you that type of blood loss unless it's coming from the abdomen.
And I'll also add, I think you now have a chest tube, so you have, in some ways, a window into what's going on that's dynamic. You can look at the tube, and yes, there may be 600 out, but you can easily look and see what is coming out minute to minute. And I didn't hear the weight of this kid, but I'll guess this is, what, a 40-kilo kid.
40 kilos, what we guess, yeah.
At 40 kilos, you've got 3 liters of blood with 600 loss. You're at a 20% blood deficit from your chest. If that is down to a trickle and slowing, then, and I had to make a bet, I would bet on the belly.
I think too, we know we have that lumbar step off in a 8-year-old skinny kid who is now not hemodynamically stable. We have to worry not only about solid organ injuries, but aortic injuries, big mesenteric injuries.
Head injury.
Yeah, we definitely got that also. I would love a scan, but again, it sounds like we're going down the path of we're going to get in the scanner and we're going to code. So,
yeah. Dr. Nadich.
So we went to the scanner and it was a couple of reasons. Number one, does this kid need a bolt, a cranny? What else needs to happen in the OR? The kid was responding enough that we felt like we could keep up enough to get through the scanner on the way to the OR. And we still weren't sure which cavity we were going into. Y'all made really good points about the fact that bleeding was probably from the belly. And we were hoping it would point us to one place or the other. So it didn't. She did not code in the scanner, I'm happy to say, or pre-code even, if you will. But while we were in there, she did come to lose about 2 liters total now of blood out of that chest tube while getting from the trauma bay to the scanner to the OR. And we didn't wait for the radiologist to call us. We just looked at this and said, well, it looks like we're going into both cavities potentially. The aorta looked fine. I don't have a picture of that. And her head CT was actually normal.
So are these white things in the liver in vessels or not in vessels?
This?
Yeah.
That's in vessels.
Okay,
There
good.
was no active extravasation noted from the spleen or the liver. You can see you can see the spleen and the liver. There's definitely fluid around them, and they look very irregular. So we're thinking there's probably solid organ injury there too, right? But the OR, given her persistent transient responder phenotype, is where we were headed. And when we got there, well, based on that, what cavity are you guys going into first? I think I know the answer, but.
Belly.
I like the belly better.
Chris?
Yeah, I think you're right, though. You're worried about you're going to need to get into both sides.
Belly.
Yes, I would start with the belly.
So we started with the chest. We had 2 liters of blood out, got into the chest, lung looked fine, mediastinum looked fine, saw the liver and said, okay. Then opened the belly. When we got into the belly, packed all 4 quadrants, no stuckus anywhere. There were a few mesenteric avulsions in the small bowel and the colon. Quickly stapled those off, left discontinuous, obviously. Slowly removed the packs. No bleeding in the pelvis, no retroperitoneal hematoma, no bleeding from the spleen. But there was bleeding from the right upper quadrant. And as we took the packs out, we could see that I could see the lung, and we could see the diaphragm was avulsed from the lateral chest wall. And that's where a lot of that blood was coming from. Some from the mesentery and some from that. So we sewed the diaphragm back in place, put a chest tube back on the right chest. And then would you try to close it? Oh, and in the OR got 7 units of blood, 7 units of FFP, 2 of platelets, some cryo, had gotten the TXA upstairs in the trauma bay, and was still requiring ongoing resuscitation, but was stably, mildly hypotensive, systolics in the 80s to 90s, pretty normal for an 8-year-old. With mild tachycardia, still needing resuscitation. So would anyone have put her back together and definitively closed her abdomen at this point? Okay.
Is she cold? Is she cold? Does she have a tag?
We did not have a tag at that point.
When you get that much FFP, do you even need a tag?
Pardon me? He's from Pittsburgh. He's
Here we go.
Tag everybody.
Pittsburgh again.
Okay.
So we did not. At this point, we're still doing the MTP. We're not doing goal-directed therapy. We're just following that protocol until we've kind of hit a place where we feel like we can actually pay attention to those kind of numbers.
Okay.
So we did not close the abdomen. We put a PAX in and left an abdominal wound back on and brought her back to the PICU.
Dr. Gaines wants cryo. It's okay. Okay.
Oh, if I didn't mention that, she did get cryo.
Okay,
Cryo.
Okay, good.
So the next 24 to 36 hours, the patient had responded to resuscitation. Hemoglobin had stabilized off at about 10. We came off the MTP. She wasn't bleeding from her wound vac. Her chest tube output had gone serosanguinous. She was on a little bit of pressors, requiring a small amount of epi and norepi, with an adequate CVP from that resuscitation. And then
Jessica, can I stop for a second? Did you guys get see the spinal fracture on the CT or not?
Yeah, you could see it.
Okay, was it
You could
bad?
see a step off. There was no big epidural hematoma or anything like that.
Okay, all right, keep going. Sorry.
Yeah, no worries. And the vac was there. So in about 36 hours, we took her back to the OR and re-explored. No bleeding, bowel was pink, but she was still on epi and norepi. So because of that, we decided maybe it would be best to give her another day or 2 rather than do 3 bowel anastomoses. Would anyone have done that if you're on low to moderate doses of pressors?
I don't think so.
Yeah, I don't think so either. I think I probably would have waited another day.
Yeah, it kind of nauseates me. Okay. So that same night, off of all sedation, She's not really waking up much. Has brainstem reflexes, but not moving the uppers or the lowers. And her GCS was not improving. So we got a little concerned. What would you do at this point?
Let's see, Katie, what do you want to do? GCS not getting any better.
Yeah, I mean, I know there's no space occupying lesion, but sounds like she has some kind of brain injury, like a DAI type picture. Are you maybe like, do we want to do some kind of bolt or something like that? We're worried like she's got no response. You know, I would think about it. I would talk to my neurosurgery buddies about it.
Yeah, so we're worried about her head.
Okay.
So we started by repeating a head CT, and at this point she had cerebral contusions, no big mass effect from any large lesion, but diffuse ischemic changes with early uncle herniation.
Wow.
Yeah. So that night, she initially had an EVD placed. That was the initial choice by the neurosurgeon on call. And the next day, another neurosurgeon came on and popped her top, did a bifrontal decompressive craniectomy for persistently elevated ICPs in the face of aggressive treatment of her TBI with ICP management attempts. And that's just her basal cisterns are basically gone at this point. So she went back to the PICU after her bifrontal craniectomy. ICPs were still elevated. This is the day we were thinking maybe we would be going to close her abdomen. Her pupils are sluggish, but they're reactive. She's got corneal reflex and she's got a gag, but that's about it. And there was a discussion initiated in the PICU as to whether or not it was appropriate to proceed with closing the abdomen versus waiting to see if she declares herself brain dead at this point. She was off of the norepi and on very low dose epinephrine at this point, but otherwise had stabilized.
All right, Dr. Newton, what would you do?
I wouldn't close her yet.
Russell?
Agree.
Richardson?
I think it depends. Depends on what, how moribund you think it really is. Because I think we've all been in these scenarios. And sometimes they end up dragging out for longer and longer, and then you do lose your window. So
I would absolutely, yeah.
I don't think I would, but I would. It just depends on the whole overall scenario.
I would close her. I'll tell you my thought process on this is either you're alive or you're dead. This patient is clearly not dead. And so if you are not dead, I blindly assume that you're going to get better. And until you prove to me that you're not going to get better. So I probably would not alter my plan based on the ICP for the same reason that Ward just said, which is you may lose your window.
So that was our way of thinking. She's not dead, she's alive. Let's proceed. So she went for an abdominal closure, did all of her bowel anastomoses, and then she slowly got better. Got an MRI of her spine post-update 4, which confirmed a chance fracture at L102 plus some ligamentous stuff in the neck she needed a collar for. Hospital day 8, she developed peritonitis and free air. She had a cecal perforation. Maybe it was a serosal injury. It was distal to all it was distal to all but one of the anastomoses. So we fixed that and then diverted her proximal to that. A few weeks later, she had woken up, got out of the PICU, had her cranioplasty done about a month later. And yes, she was paraplegic, unfortunately, and underwent a posterior spinal fusion 2 months later, and then had her ileostomy closed a few months after that. But she's actually a pretty happy, although differently abled child. She's paraplegic. She has occipital blindness, but she eats, talks, goes to school, smiles, laughs, enjoys her differently abled life, and has a ventral hernia that we need to fix at some point because of, all the laparotomies and such. Her fascia kind of fell apart.
Wow.
So kind of rushed the end there, but
no, it's cool. It's a cool case, and we any, I'm probably gonna hold comments because I think we're already at 30 minutes. I wanna try and get through to the next case. But great case, thank you so much. And I feel like we learned a lot. By the way, I did not see that that scan or any of the slides beforehand. Jessica kept this all under wraps.
All right, guys, I got another case.
Awesome.
I got a lot of slides, but I'll try to, let's get through this. So no disclosures, but this family has given me permission to tell the story. So Island Park, Idaho, I don't know if anyone's been there. It's in the Intermountain West, a beautiful area right outside Yellowstone, where there are a lot of ATVs. And we always say this is where kids go to get hurt because we get a ton of kids from this area. But this is our patient for the day. He was riding his bike and unfortunately got run over by this guy. So Fizzy D was coming in. He's a 5-year-old. He got run over by a camper trailer. An amazing story. Like, this tiny little town only has one ambulance, and they had just picked up a guy with COVID, like a 55-year-old guy with COVID. And this was kind of the beginning of the pandemic, and they swept in and picked up this 5-year-old in the same ambulance. So at a COVID exposure, he went to the local level 2 trauma center that is awesome. And there he was diagnosed, pan scan, diagnosed with an open pelvic fracture with significant bleeding, an obvious rectal injury. His heart rate was in the 150s. His blood pressure was reportedly good. His GCS was 15. He weighs 19 kilograms. They intubated him. They sheeted his pelvis. They packed, I wish I had pictures of this, but the whole situation was so intense, I don't have any pictures. They packed this massive open pelvic wound. Prior to arrival, he got 8 units, and this is a 5-year-old. He got 8 units of reds, some platelets, some FFP, and 1.5 liters of crystalloid in addition to TXA. So he was real sick. I took multiple calls from the guys up there. They were asking me, should we open his abdomen? What should we do? I said, just try to keep this kid as compressed as possible and get him down here. This is a multiple hour transport. So we were waiting patiently. And when we finally got him, he was intubated, had good end-tidal CO2, equal breath sounds. He had positive femoral pulses. I couldn't really get pedal pulses. His blood pressure was 124/64, and his heart rate was 153. His GCS is 3, but he was sedated. And I know that he was 15 at the other hospital. This is actually his outside hospital chest x-ray, but it looked pristine. Here's his pelvis. So there was also a CT scan just to kind of describe the pelvic injuries. He had bilateral pubic rami, a right ischiopubic ramus, a left SI fracture, and he had blushes all over his pelvis on this initial CT scan. On secondary exam, he had this sheet that was covered in blood and then also had all this packing that was soaked. What's the plan?
Whew. Pelvic blushes everywhere.
Everywhere. 5-year-old, like everywhere. And this kid is white as a ghost. And the ICU doctor and the trauma surgeon in Idaho are also white as a ghost.
Okay. Let's see, Dr. Nadich.
So if you already activated your MTP and start balancing out this kid's resuscitation, I would think that would be kind of my first steps. I don't remember if you mentioned IV access. I'd make sure we have good IV access on this kid as well. I guess in my head, I'm trying to decide, are we going to IR or the OR and then IR, or just, and my thought is I didn't get a good idea of it. Is he responding to resuscitation at this point? He says he's white as a ghost, so probably doesn't sound like it.
Well, he is though. I mean, his heart rate's in the 150s, but his blood pressure is in the 120s. He's holding that kind of stable at this point.
And yeah. I mean, I think you're going to the OR and then IR. I think that's what I would do. Okay. I think that you probably have pelvic bleeding, possibly from, obviously from your CT scan, but you've got blood all over the bed. So that blood's got to be coming out of him from somewhere. The rectum is my assumption. I don't remember if you said that's where
the open wound is like this big, and there is Kerlex just like coming out of it, soaked in blood and stool.
Oh, that's horrific.
Dr. Richardson, how much whole blood do you guys stock in Pittsburgh?
Can you send me whole blood?
Three of three units. We have a unit in our trauma, a unit in the blood bank, as well as the OR. And whenever we activate an MTP, a unit comes with that.
All right. So, Katie, you joke about that, but actually Pittsburgh supplies our whole blood. So we get
it to you?
Yeah. No, we buy it from Pittsburgh.
All right. So I heard one. Let's go to the OR. Anyone else?
Oh,
OR then IR.
Christopher?
yeah, no, I obviously I agree with what Jessica was saying. You think of IR, OR back and forth of which is first in all of these. And I would certainly call my interventionalist and get on the phone and get an opinion. But from what you're describing with that big open wound, and I'm presuming this is by his rectum on his backside, the wound.
Yes.
Yeah, I think you're probably stuck. You're going to have to go to the OR and do some control first, and you're going to have to divert his colon, obviously. And the first priority is to see if you can find a single source of bleeding somewhere that you can.
Where you going to IR or OR?
OR. I agree with Chris.
All right.
I've certainly seen. I also saw someone even without a large internal component, but the soft tissue component alone, you can lose a ton of blood from that alone. So that's not going to be controlled in IR. In the absence of that, I'd probably hem and haw a little more in that scenario. In this scenario, I go to the OR.
All right.
Yeah.
Dr. Russell.
And what's the first move in the OR?
Well, I think look at the wound and see what you can see with the wound.
Raboa, aortic cross snap.
All right, so that's what I did. So I called in a bunch of friends first. I had a few hours to get this all planned out. So I called in our orthopedic surgeon. I called in a urologist as well. And we went for it. So there was, we had 3 big IVs. We were all set. Our anesthesiologist had all the blood, and we pulled the packs, and there was a lot of bleeding, more bleeding than I've ever seen. I packed it. We basically just looked and shrieked, and it was bleeding a lot, and you couldn't really tell where it was coming from. And there was an obvious anal rectal injury, and we packed it. And then his abdomen was getting more and more distended, and I was worried that he was developing an abdominal compartment syndrome also. And so then I lapped him. And when I lapped him, there was a liter of blood. There was no, it was kind of just soaking through the peritoneum from this massive retroperitoneal hematoma. Now what are we going to do?
Was that a zone 3 retroperitoneal hematoma?
Yeah, I mean, big retroperitoneal, but it was like, it's only a 5-year-old. So it was like a whole retroperitoneal hematoma, like just, it was whole hematoma. So, so we were actually doing pretty well still. That we were keeping up with the resuscitation. We had these packs down in this big open wound, and it was still bloody, but it wasn't like bleeding through the packs. What we did is we stapled off the sigmoid just to stop the contamination from below. And then his bladder was massive, and we assumed there was a urethral injury that we couldn't 100% tell. So we put a suprapubic tube in. My buddy, the orthopedic surgeon, didn't think that we would stabilize it much tonight and didn't need to worry about it for now. So we put a temporary abdominal closure and took him to the ICU. His total resuscitation at this point is 11 units of pack cells, 4 of FFP, 3 of platelets, some cryo, and still that initial 1.5 liters of fluid. But he was doing, I think, okay. His hemoglobin was 14. He gotten 360 mLs per kilo of resuscitation at this point.
Wow.
And we were transfusing, but it wasn't like full court press at this point. So now, here he is. What's our plan now?
Going
to IR? Jessica, are we still going?
I mean, you said you've kind of stabilized out. My inclination is yes, still go shoot the gram. Go see what you get before you get behind. You've caught up. You know that there's extravasation. You know head of massive retroperitoneal hematoma. So I would say yes.
Natrika, would you go IR?
I would probably do a CTA.
Anyone else?
Were the iliacs were fine on the initial scan?
Yeah, the iliacs were fine, but multiple blushes like right off the iliacs.
I know. I think I know what Ward is getting to, which is that if you got that much bleeding, you're going to have to dissect the aorta of the iliacs and find where the iliacs are bleeding, because there are only 4 things that give you that much bleeding in the pelvis, and all of them start with the word iliac.
Yeah. So we went to IR. And honestly, there wasn't that much bleeding by the time we got to IR. So now it's like several hours later. It's like 6 o'clock in the morning. So a few hours later, and we found a lot, like there was a blush down in the internal pudendal, but nothing bleeding off the iliacs. We embolized the superior and inferior gluteals because we thought that's where the bleeding was coming from on that CT scan that we initially had, even though there wasn't a blush on our angio.
So someone asked about preperitoneal packing, which I think is a reasonable question. I don't do it, but so I don't think it's a bad way to go, but I've never done it, so I wouldn't.
Yeah, I don't know. I opened I fully XLAP the kid. So Natrika, would you have tried that? I was packing,
this is already an open
packing from the open wound.
Yeah,
the whole wound was open.
Right, it's already open, so I don't know how you do that.
Yeah.
Okay.
So I just want to bring up, so that superior gluteal artery, what does it feed? I mean, it feeds the gluteus maximus and all the skin in that area.
Ooh,
so I don't know if this hurts me going forward. But when do we use IR in kids? I don't know if anybody has strong opinions on this, but certainly a good topic, probably too big of a topic for this grand rounds. But if you look at the PCARN data in kids, the average time to getting to IR is 7 hours, which was the same in this case. So, the conclusion in this study is just the emergent use of angio and embolization kids is real rare,
Yeah, but that's written by Scaife. You can't really, no.
Yeah, I mean, so, and it was the same here, though. It's not like I went in an adult patient when I was a resident, we would go immediately to angio or to the hybrid room for some of these pelvic fractures. This, we're 8-9 hours into this before I actually got to angio. And, there's a bunch of papers out there just looking at adult versus pediatric trauma centers on this angio stuff, but I did it. We angioed that kid. We took him back to the OR on day 2, and he got some pins in his sacrum. He got a X-fix of his pelvis. We were able to find the other end of the urethra. So we placed a Foley across this urethral injury, and then I gave him a colostomy. Here's what his pelvis looks like. Pediatric pelvic trauma is real rare. The bone is more flexible, and it takes a lot of force before it breaks. And then the periosteum is so strong that it doesn't bleed as much. And the vessels clearly are in these healthy kids, they vasoconstrict really well. Multifocal ring fractures are real rare. And then even when they happen, they rarely bleed. I think the difference in this case was that it was open, right? So there was none of that compression, and the kid was just bleeding out.
I'm still super impressed that this stopped bleeding on its own. And I mean, not impressed as in surprise, but it's like, yeah, that happens. Kids stop bleeding. Anyway, keep going.
Yeah. So, just another study, just looking at how rare it is to actually angio a pelvis in a kid. Out of 163 pelvic fractures, 7 got angioed and only 3 got embolized. But about 25 of those 25% actually got some kind of operation to repair the pelvis. So this is what I started dealing with in this kid, right? So now the bleeding has stopped. We're stable, all up in our COVID gear because of that COVID exposure. And here's what his backside started to look like. And he had this Morel lesion that really continued to haunt us. So, this is a shear injury where the subcutaneous tissue is off the fascia. It's like a closed degloving injury, most commonly motor vehicle crashes, and then sports injuries, actually. And it causes this massive lymphovascular leak. And there's not a really great standardized treatment in kids. I read a ton of different kind of ideas people have for the best way to take care of these. But his declared itself. I mean, you can see it here over several weeks, and it's incorporated within this pelvic fracture, and ended up just being a huge morbidity for him. So, the kid got a ton of operations. He had this suprapubic tube for a while. This was one of those complex VACs that I know you all know about, incorporating the X-Fix into the VAC. But eventually he did get skin grafted, 3 months after his injury. And then he eventually did get his urethra repaired. And now he urinates normally with control, which is pretty awesome. It was like a 3 centimeter injury. So, the kid is, you can see how his injuries kind of progressed here. He eventually got that X-Fix off and we got him home. This is his voiding cystourethrogram that you can kind of see how he is able to pee without a stricture. And here he is now. So I stimulated his anus with the Pena stimulator. I didn't describe it in great detail, but there was a major anal rectal injury. And it's all healed. And I think he's got about 50% function, about 50% of his sphincter complex functions. So now what do we do, guys?
Dr. Richardson.
I think you have a conversation with the family and the kid. I think you can get this kid to be clean. Overall, you may need things like appendectomies and cecostomies associated with it, but you certainly can get him to be clean. It is a lifelong issue and stuff. I think there are things you can do to certainly put him back together and be clean. Continence is a different story, but you can be clean in between. Again, whether you do cecostomy, ileostomy, whether you slow them down a little bit, there are certain ways in which to deal with it. But it is a conversation with the family so everyone understands what this means.
Dr. Newton, I know that you're having some bandwidth problems.
Yeah, sorry about that. I'll just keep my camera off just so I can continue to talk. But I agree with Ward. I think it takes some creativity, but you can, I think, get this kid functional. You need to have, of course, a really tough conversation with he and his parents up front so they know what they're getting into.
Jessica, Nadich?
Nothing to add, but I agree. You got to give it a shot.
All right.
All right, guys, we'll work on that this summer.
Awesome. Great case. Thank you so much. I think Dr. Richardson is next up. If you want to stop sharing. Awesome. So we're giving Dr. Richardson a lot of grief because he has access to whole blood that the rest of us are just completely jealous about.
That's all Dr. Gaines there. And our blood bank people. They've been honestly great with their support, and it was really their initiative initially.
Nice.
So nothing to disclose. So this is our beautiful city and our hospital here.
Wow.
And we have a fairly decent catchment area. Here we are in Pittsburgh here, and we go all the way to the middle of the state, down to a large portion of West Virginia, Ohio, and up to New York. So this is a 4-month-old male who's transferred from an outside hospital. He has a gunshot wound to the left chest, left arm, and the right abdomen. Intubated bilateral IOs. En route, he's given blood for hypertension. And these are actual alerts we got. 1.5 hours for the first one. Next one was the patient's intubated now on the vent. And then the 15-minute ETA, blood products are being started. His heart rate is 170 with a respiratory rate of 28. And they could not get a blood pressure. So what do you do?
All right, Dr. Nadich, you're first up.
It sounds like you're gonna need that whole blood of yours.
He's too young. Too young. He's only 4 months old.
Oh,
Okay.
4 months. I'm sorry, I saw that. I thought it was 4
4
years.
months. 4 months old.
So do you guys have regular old pack? Do you regular old MTP at your place? That's obviously, if you're not getting a blood pressure, I'm concerned this kid's way under resuscitated, actively bleeding, and needs an intervention there. Clearly he's gonna, you said he's already intubated. Sounds like left chest, probably gonna need a chest tube on that side unless they've already done something to decompress that, get a tube in there, but I don't think you mentioned that. And then also the belly, I would call the OR and tell them we're probably gonna need to go there as well. Assemble my team, do the pre-arrival debriefing, make sure everyone knows their roles.
Dr. Russell?
Yeah, I'm with you. That all sounds good.
Dr. Newton?
Yeah, I think you're heading to the OR. I would make sure that you figure out what kind of access you're going to need. You have the right size stuff before the kid gets there.
So we have a level 1, level 2, and level 3 activations, but we also have something called red trauma. Red trauma bypasses the emergency department, goes straight to the OR.
Oh, wow.
So I'd probably make this a red trauma at my place.
Have you guys taken care of many 4-month-old gunshots?
No.
We've had a few. Our babies tend to get stabbed. Yeah. The stories I could tell you they're just sad, So the answer is we've had a fair amount of penetrating trauma, but not gunshot wounds.
Yep, I have never seen this. I don't think any of my partners had seen this specific thing before. The 4-month-old.
Oof. Does he? Yeah. Oh.
So here you go. Here's what I was talking about. So this is a little change quote from the House of God. So I think one of the first things you do at a trauma, the first procedure is take your own pulse. I think we've also experienced this being at pediatric level 1 centers, is that when the younger the kid is, the higher the tension is in that room. So I think that's one of the first and foremost things that you need to do in order to better gain control of the room itself as well.
Yep.
So we can't technically activate the mass transfusion protocol without the patient being there, but we knew this kid was likely going to need it. So a discussion was had with the blood bank about that. So just short of activating it, a team huddle was had as well. And unlike for the adult people who are on, unlike the adult trauma centers where you're going to get similar sized patients and chest tube can go to everyone, and in the P center it's not like that. So we can't have all these things available at all times. So we made sure we had the chest tubes out, introducers and all that stuff, given the patient's size. So on the primary survey, he's intubated. There's decreased breath sounds on the left, palpable but very weak femoral pulses, heart rate of 204. It really can't get a blood pressure. He has a wound in his right upper quadrant, a second wound left chest, inferior and lateral to the nipple with lung herniation. He has 2 IOs in place in bilateral lower extremities. Chest X-ray is a wide out with the right mainstem intubation. So he had a chest tube placed with 100 cc blood came out. Pack cells were given and FFP started. This is the 2 holes that we saw.
Yeah, that's not good.
So Chris, you're saying that there's no aspect of this that you're not worried about.
Yeah, that's not good.
Yeah. Okay. Katie, you want to narrow that down for us a little bit?
Yeah, I mean, we've got, it's kind of similar to the last case where we've got to go in both cavities. It sounds like, I mean, you got lung coming out of one hole in the chest, and then this kid is unstable and he's got a gunshot wound to his abdomen. So you're going to need to be in the abdomen also. I think we've said it, but the number one thing, we can't get a blood pressure. We need to get some good IV access or IO access, central line in this kid, and start getting some product in him.
Okay. Sounds good.
So yeah, so we lapped him. One of the things I do want to point out with here, I think sometimes, at least at our place, I think this is true, lots of places, is the ED can be somewhat chaotic. And certainly the adrenaline was running for a lot of people, and there's a lot of people in there. It happened in the middle of the night. So one of the things, once we got things rolling in terms of blood going and those type of things, and chest tube in, I got him out of the ED into the OR.
Yeah.
Because obviously resuscitation doesn't just take place in the ED. It also happens in the OR. And one of my biggest things was to get him out of that OR, out of the ED to the OR. He still needed to be resuscitated, but I thought some of that could be better done in the OR as well. And the left chest tube came out in transport. So bilateral chest tubes were placed. Femoral arterial line was placed as well because we had no blood pressure. Still lap on him. Found just a large amount of blood in bilateral upper quadrants, right, greater than left. The bleeding was controlled with packing. Needed additional access. So at that time, it didn't seem like it was welling up too much at that point in time. So did a cut down in the opposite side for a venous access there. So he now has a femoral arterial line as well as a venous line in opposite legs. So then we started slowly pulling the packs out. Nothing in the pelvis. The left diaphragm had a hole in it. There was 2 really large gastrotomies. Basically, the lesser curvature was completely blown out. Big hole in the greater curvature. A hole in the diaphragm there. Really wasn't a large amount of blood coming out of the chest tube anymore there. So that's what we saw on the right. And a blown out D2 with the colon injury.
Oh, okay. Dr. Nate, did you get first stab at this one?
Good. Go back to the last slide. Can you go back to the last slide? Okay.
Left
So
diaphragm, two holes in the stomach with active bleeding, blown out D2.
Stomach is bleeding like stink. There's these huge
stomach's bleeding like stink. I
then the
assume you're
D2
bleeding.
blown out.
You're probably bleeding from like the gastroepiploics or something like that, right? So you got to figure out where that is and stop that. With suture ligatures probably, and then
not IR.
No,
Okay.
so that put a stitch in that.
Okay.
Okay, so you.
Yeah,
So
I have no pretty pictures or X-rays for this case, as you can imagine.
like, you didn't think to stop and pull out your camera. So you put some figure of 8s in those, get that to stop. Sew up the holes in the stomach. The liver injury, I just pack that, forget about that for a minute. Eventually you'll fix that diaphragm, but that's lower on the list priorities, but you get that done. The colon injury, I'm sorry, what was the description of that?
There was just a colonic injury, a small hole in it, tear in it.
Okay, close that. And then D2, what was going on with D2?
About 50% of it's gone.
That's bad. That's bad. The lateral aspect, the pancreatic aspect of it, which part?
Lateral aspect, pancreas was not obviously injured.
I mean, you're the one staring at it. I would try to debride, fix, and then do you, then the question is, do you do a GJ and exclude, or do you fix it and put a T tube into it?
He's still on
Depending
pressures.
on what it looks like.
He's still on pressures and getting blood.
Okay.
Let me ask the crew about that. So let's assume, is it fair to assume that we're going to stop the bleeding in the stomach and then move to the duodenum?
To move to the right side, yeah.
Okay, so D2 is missing. Who wants to do what? Katie.
I'm not doing a Whipple. How about that? That much I know.
It's not
Okay.
missing. There's half the wall is still there.
Half the wall is still there. Boy, the optimist. The duodenum is half there. Okay, Katie.
Yeah,
Right.
I mean, that's the tough place to have an injury. I think I'd debride, quickly close what you can, drain, backpack this kid, get him to the ICU. Let's get him on antibiotics and then come back to fight when he's a little bit more stable.
Do you guys have vacs out there for a 4-month-old?
Yeah, it's get him back. I'll make it.
Do the usual vac. They have the tiny sponge.
Yeah, we
They're
vac
all
our
tiny
neonates.
ones. Just
Yeah.
make the sponge smaller.
Yeah, it's a little one. No,
All right,
and
Chris.
I think you've got to stabilize and get out and come another day. So I
Yeah,
agree.
we got to get him stable.
You wouldn't do a Whipple at the moment. So the question becomes, what's your most effective way of stabilizing? And I think you can put a drain in the distal duodenum and purse string and pull that out, get a mallet caught in there that temporizes thing. And however the tissue allows you to control the proximal staple, suture, whatever it may be, and you temporarily exclude, and then you're going to have to come back. You need to figure out as best you can, is that ampulla intact, and and what your biliary tree look like. So I would take 2 seconds and try to see it if I could.
Okay,
How do you guys do your exclusions?
I don't. My view on this, and I kind of leaning a little bit more towards where Chris is. I would do a tube duodenostomy, or I would take a piece of jejunum and sew that circumferentially around the hole in the duodenum to create a patch, or I would close it vertically, or I would do a Nissen closure. And I know that's 5 different ways, but that's kind of the way I think about duodenal injuries in 2022. Is I'm going to use one of 5 different ways to close this, rather than do a trauma Whipple or punt down the road, because I think that your best chance of getting it closed is today. That's my bias.
So for those in the audience, we put a silo on. This was our spring-loaded silos look like. Because we just want to get in and out.
It's very cute.
So the diaphragm was repaired, gastroscopy was repaired, and the bleeding from the stomach was mainly from the stomach mucosa. There were just these huge tears in there. So just oversew those quickly. I did perform an exclusion. The pylorus is very easy to find through the hole. So just put a proline in that. The right quadrant was just packed. The liver injury itself wasn't very bad, and that was easily controlled with bleeding. Silos placed, and then right up to the ICU, right? No. So bilateral lower extremities were tight from the IOs. So exactly. So he had bilateral 4-compartment fasciotomies and left foot fasciotomy with wound vacs placed. He got, again, this is maybe a 6 to 7 kilo kid, 8 units of packed cells, 6 of FFP, 2 platelets, 1,500 crystalloid, 500 albumin, EBL of close to 2 liters is estimated. He was taken to the ICU for further resuscitation. He was also cold, as you can imagine, and directed correction of his biography with plans for a second look. We talked about that already. So he went back on hospital day 2. There was still some blood welling up, but it wasn't nearly as bad. There was a bleeder off the right hepatic artery that was controlled. The transverse colon had been oversewn before, which was just resected and left with discontinuity. Did a cholecystectomy because he used it for cholangiogram to see where the ampulla was. D1 and D2 was repaired primarily, and a lateral tube duodenostomy was placed, and a gastric J was done with wide drainage of the area, and then left them open, came back. Interestingly, on the 5th day, there was noted to be some ischemia of the TI. And this, I'm not sure if this was secondary to hypertension associated and also with some packing, whether it was some overaggressive packing by me. And there was some ischemia secondary to that. I don't really know what that was. And then, like the previous case, there was some perforation randomly there as well. So that was repaired. He had ileocolic anastomosis as well. He finally went back for a formal repair of the stomach because the stiffy line opened up, a GT was done, and NJ was passed through the GJ anastomosis, and the fascia was closed.
Quick question from the audience. Sergio Castaneda asked, how is the ampulla?
It was fine. It was fine.
Okay.
And so yeah, you could see it through the opening, but then the cholangiogram also made it more definitive, so it wasn't involved. And there was plenty of room away from that to repair the duodenum.
Okay.
Obviously, it's one of the injuries where no matter what you do, you feel like you're going to choose the wrong thing and you're going to have a bad outcome. but you have to choose something. Did have some bump in his creatinine, which came back down, didn't require dialysis or anything. On hospital day 21, he was extubated and ultimately transferred to the floor on the 24th, hospital day 24. So is this a save?
That sounds like it.
Yeah.
Yeah.
Yeah, we think so.
Yeah.
What are we missing?
So patient, he was hypotensive without blood pressure for a prolonged period of time. So patient was discharged rehab at 45-day length of stay. He had a couple of minor things for like the GJ tube coming out, that kind of stuff, but no major hospitalization, surprisingly, no major complication from that standpoint. But he has major cognitive functional delays, secondary hypoxic ischemic encephalopathy. He did have a tube study. His pylorus is wide open, and most of the things goes through his pylorus, and it looks pretty normal actually. But he has dystonic cerebral palsy, dystonic posturing. He's fed almost exclusively through his gastrostomy tube. So that's why I bring that up. It is yes, he's alive, but unlike the other case, he does not have a meaningful outcome. So this is, for me, this always makes think of the prevention aspects. That's really what the way to make this better is prevention. Education and teaching with prevention. Because as we all know, it's so prevalent, and we certainly do these safe storage events. And this is one of the ones we did over the summer, towards the end of the summer. And this just says how many guns that people have. And about 21% of the people that went to this event had 1 to 3 guns, but 30% of people had 10 plus guns. Yeah. And then this is asking these same people, are your firearms in your home currently stored in a locked place? 61% actually said all of them. Almost 20% said some of them, which obviously some of them is like being a little pregnant. Doesn't really matter. You still have access to them. And 4% actually said none of them. So this is where we can make a difference. And yes, got the kid through an event, but did we? Is really the question. It's a case that we hadn't seen. I don't think any of my parts had ever seen, and I certainly hadn't seen yet. And hopefully I don't see this again, type of scenario.
And that was a sad one to end on.
Rough.
Yeah, it was a great case, but the reality is, they say geography is destiny. And going back to your very first slide, Ward, it took a long time to get to Pittsburgh.
Yep, they couldn't fly because of weather as well. So it was a problem.
Great case, well managed. You can't treat the patient that isn't there.
Yeah.
So,
yeah.
All right. I think we have time for one more quick case, which brings us to Dr. Newton, which luckily puts me off the hook for doing my case. So, Dr. Newton, you want to share screen?
All right. Yeah, let me pull this up, and that should work there. So this is a 4-year-old, and so it's not there, but we estimated roughly 20 kilo child who came in by private auto, and the story was a presentation that he got a skull burn in the shower. And when he came into our triage area, so there's no ambulance, he was pretty minimally responsive. So we swept him up into our trauma room and activated things. You can see his GCS is not good, so he's minimally responsive and kind of waxing and waning. He's really cold. Vitals are okay. Oddly enough, despite the report of getting hurt in the shower, he's fully clothed and dry. So we're really not sure what happened. So we begin to do the normal trauma routine, the A, B, C, and you can see all the vitals there. And once again, he's pretty cold. It looks like he's got about a 30% burn full and partial thickness. It's over his face, his back, and a little bit coming over his right shoulder. Lots of bruises.
So Chris, just so you know, we're seeing the slide, your whole slide view. So the slides are not advancing. I don't know if they are for you.
They are for me. Here, let me change how I'm doing this. Excuse me. Is that working for you now? No.
That's better.
Okay.
Okay.
Let me just change how I do this.
Okay.
So you should see ABCs there. Yeah.
Yeah. So you may see something that says switch between presenter screens if at the top.
Yep. And that's not letting me do it. Well, as long as you can see where I'm going.
Yeah, we're good. We're good.
It's okay. So so yeah, he's got burns everywhere. He's got bruises and somewhat of a distended abdomen. So and these linear discolorations in the left lower quadrant. So that's your initial presentation. Thoughts from anyone? What do you got?
All right. Ward, I think you're up. What do you?
So clearly the story doesn't make sense at all. Getting even initially without some of the other things, even if he came in wet, a skull burn of that degree from a shower doesn't make sense. The altered GCS doesn't make sense. There's bruising all over the place. So certainly thinking NAT. And obviously, as we're all aware with NAT, it's fair game. Everything is really fair game with this in terms of what could be injured and stuff. And there could be some chronicity to some of these injuries as well, given the NAT picture. So obviously, I think it needs to be resuscitated. Ultimately, need to get some imaging of him. And in these scenarios, we don't commonly pan scan people, but this would be one scenario where we would, just because you don't have a good story. You have no idea what's going on with him. Distended abdomen. Certainly, we worry about head trauma as well there. But it needs to be resuscitated, stabilize it, then think further imaging.
Katie, any thoughts about the temperature?
Yeah, I mean, it's way too low. So I think that's like number one. We got to warm this kid up. Warm IV fluids, bear hugger, pump the heat in the room. I think ABCs first, airway okay. I kind of missed that part, but ABCs, and probably I would think about warming him up before getting the whole NAT workup.
Yeah, remarkably, his airway was doing pretty good. So we did not intubate him, initially. So he, despite my description of GCS of 11, yeah, there's moments he would wake up and he seemed to be protecting his airway, and heart and lungs sounded okay. But he's pretty cold and very cold. So we started warming him up. This is a picture just so you can get a sense of the description of the bruises over his body and where the burns are. Note, not only are we lacking in whole blood, but we are also not a burn center. Our team that was there that night began the process that we always do of calling our burn partner and beginning the conversation with the burn team of, hey, what do you think about this? And what about resuscitation, and how are we going to transfer and all of this? The burn center that we were talking to, I think very appropriately said, whoa, wait a minute, this is not just a burn. And of course, we agree with that. They began with pretty aggressive calculations. You can see his weight at 16 up there. We roughly calculated 20 at the moment. And so by Parkland, that gives him like 2.5 liters over 24 hours and 1,200 in the first 8. And so they started down that process with a bolus and a rate. Got him comfortable, dressed the burns up. You can see his first set of labs there, however, which are pretty alarming to us. and his TEG, we did that. That was okay, but still has he's a little anemic. He's got a little bit of a coagulopathy, and his lactate and lipase were pretty alarming. So
Wow.
Burn Center doesn't accept him.
So, all right, Dr. Nadich.
I think Ward already covered this kind of, and so did Dr. Russell. It's resuscitate as you're doing, warm, and then get images. You have no idea what happened to this kid, except clearly there was some sort of burn. The chronicity to that burn, that doesn't necessarily look fresh either. There's a lot of information we need to gather still.
What do you think about that markedly elevated lipase and AST, ALT, in a patient with a pH of 6.96?
Not good.
I mean, either it's from trauma or it's from ischemia, but either way, you got to take pictures.
So interesting. The way I put this together is this kid is incredibly hemoconcentrated, yet his hemoglobin is 8.2.
Yeah.
And yeah,
Means it's really probably like 5.
I think another thing to note is the INR, because I think an INR, I looked at the INR as well as Dr. Gaines showed previously in one of her papers, that it's a marker of how sick the kid is, not necessarily coagulopathy always. Just correcting it doesn't necessarily always make them better, but it is a marker of how sick the patient is. So when I see a markedly elevated INR, especially with a normal TEG, that makes me think they're a very even sicker than they're appearing.
Yep.
Oh, nice change. Thanks.
Right, I'll try, even if I can't get the rest. So I agree. Everybody was pretty worried about this kid overall. We did, as everyone was saying, we did the temperature and the ABCs, and we also did a fast, and it was pretty positive. There's a lot of fluid.
Well, wait. Hold on before we move on. I mean, does that bother you, Katie Russell?
Yeah. He's got a liver injury, and he has a pancreas injury too, probably. In addition to whatever else is going on in his abdomen.
Jessica, does that bother you?
Talking about the positive fast?
Yeah.
I mean, yeah, but I don't think it changes what I'm doing.
Ward?
Exactly. I'm not a big proponent of fast, especially younger kids. It doesn't generally change what I do with them. So, and I can't tell you how many times people say, oh, it's a positive fast, and then you get a scan anyways, which it doesn't alter what you're doing, and there's nothing on there. So yeah. I'm not a big believer in fast, especially younger patients.
I also think that if you do a fast after a patient has had significant resuscitation, it's always going to be positive, because in young kids, because they put so much fluid in their abdomen. So all right.
Yeah, and we are already pounding them with fluid. That's already beginning. So
non-informative. I mean, it could be the end of the world, or it could be nothing.
The standard admin with the vital signs, that alters my decision making more than positive fast.
Yeah,
he's got a liver injury. I really think whatever the fast says, I don't care what the fast says, but he still got it.
All right, okay.
His abdomen is getting more and more concerning. So, and as his abdomen's getting more and more concerning, our team begins to think, what's next for this kid? Because now he has abdomen and vitals that are making us think he needs to go to the OR and get a lab. Do we get a scan? Does he need blood? Because now, regardless of the burn, we're thinking, Katie, as you are suggesting, there's something in his abdomen worse than just the burn. So any consensus of scan straight to the OR?
Scan
him.
Yeah, scan, but he definitely needs more fluid than what he's gotten.
Yeah, he needs blood too.
Yep. So, let me advance. Here it comes. I will also note kind of the only off-topic slide that I got. This is our in-house algorithm that we put together probably about a year ago, just to help our team to unify on the questions of when to scan for blunt abdominal trauma. And I thought I'd put it up there because, at least the the stable screen, we have these, the 6 categories. And this kid clearly met several of them. So no matter what you thought, it's, by our own protocol, it's worth doing. Excuse me 1 second. There you go. So this is what his scan looks like. The FAST was correct. Does have fluid. It was really difficult to tell exactly what the injury was. So the liver and spleen are okay. There's no lax. There's no free air. That much we can tell. The spleen looks big and swollen, and there's a lot of fluid in the lesser sac. But even with really good radiologist eyes, you really couldn't define a lac. That's maybe if you squint real hard, you might be able to see it there. But it looks like the pancreas is not right, but that's about as much as we can say.
Is that an artifact in the middle of the pancreas, or is that real?
Yeah, well, we later found in the OR it's real, but at least at this moment in the discussion, it's as you're scrolling up and down on the screens, you really can't tell.
Okay.
There's your official reads. We also scanned his head. That was thankfully okay. And then it just so happened at this moment, we also had, a full OR. So we continued our resuscitation in this kid. And the team that was on that night called, was still asking the burn center, are you sure you don't want to take this kid? But they still said, no, that's not right. And our resuscitation is not perfect, but is beginning to catch up. And even with the beginning to catch up, his blood pressure is beginning to get softer. So, so we ultimately did get him to the OR. I guess I'm jumping my questions. Excuse me. Would anybody actually resuscitate him and do ERCPs or MRCPs or anything like that? Is that tempting to anybody?
He's
no.
unstable.
Okay.
No, he's become more unstable. There's a ton of free fluid and blood in his belly without any obvious laceration of the liver or spleen.
With a concerning abdominal exam, I agree.
Yeah, I think peritonitis kind of like negates your ability to not operate on it.
Yeah. Well, and obviously we thought the same. So he got to the OR, and you can see his fluids through the OR. And remember that 1200 crystal, or 1200 is his 8-hour burn number, but doesn't really account for, pancreas sequestration. So what we did, we went in with a scope first because we just weren't totally sure what to see on the scan. Washed out all the fluid, and sure enough, the liver and spleen looked fine, but pretty significant adhesions and inflammatory reaction in the left upper quadrant. And who knows how long it's been there. It didn't necessarily look like it was within hours. So once we saw that, we knew we were going to have to go after the pancreas, and so we opened because you couldn't see anything with the inflammatory reaction, and got down, and sure enough, there was a divided pancreas. Thankfully, it was to the left of the vessels, and so we were able to do a distal pancreatectomy. It was already almost all the way transected. We were able to save the spleen. And then of course we were fortunate enough to be able to get the burns at least initially debrided and treated.
How did you take the pancreas? How did you resect it?
Well, it was mostly already resected on its own. So
what did you do with the duct? The duct, I guess.
We completed it, and I did sutures over the duct. That there was a spot that I squinted real hard, and I can imagine. I think I saw something, and we put stitches over that area, and of course left drains.
There was a question in the chat. How was the duodenum?
It was actually okay, and and so was the stomach, which was kind of remarkable to me that that the spleen, stomach, and duodenum and everything else around this was irritated from the fluid, but there was no other lax. The resuscitation and how much fluid this kid got, in our own in-house review of this, we struggled with what was right in this kid, and were we too slow with the fluids, or did we give too much at the end? And this was, this is hard to ballpark. How do you deal with the combination of, a Parkland formula and pancreatic sequestration at the same time? It took us a while to catch up, and probably longer than I would have liked. And ultimately, at the end of the first 24 hours, he got a lot of fluid, and maybe way too much. Ultimately, however, I think the kid staying with us and not going to the burn center was obviously a really good, really good thing. He needed to have his abdomen dealt with. Then we struggled after this of, okay, at what point, because we are not a burn center, and okay, we want to get him to a place that can take care of those, but at what point is it safe and stable, and is it okay?
Wow. Katie.
Yeah, trauma comes first, and this is still a trauma patient. The burns can wait. So we're lucky our burn center is just across the bridge. So we have them come over and help us in situations like this. But I would say some kind of a telemedicine consult with those guys, if able, to make sure that you're kind of doing the right wound care. But I would make sure that this guy has recovered from this pancreatic injury, and probably on feeds before I would try to transfer him out to a burn center.
Ward.
I agree. We are also not a burn center, but our burn colleagues have been great. It's not common that we have something like this where we have a trauma that's more the overarching issue, but they've been great when they come over. So you got to take care of the trauma itself. And I know that one of the questions on here, should the abdomen fascia be left open? I would close them because he's going to swell. I think if you longer leave them open, you're not going to close that fascia later on there. So I would close them as well.
All right. Chris, you want to close?
Yeah, I think that was the last of the slides. So getting to the questions, like I said, the struggle with us was the combination of the fluids, and I don't know if anybody has any good guidance for how you estimate pancreatic fluid plus burn fluid at the same time, because I haven't seen that combo, but
the Parkland burn / pancreatitis formula, yes.
Yeah.
Little known, yes. All right, guys, we are at 90 minutes, so we need to wrap up. I think you guys did a great job, both in your presentations and with the management of these patients. Love having this. Would love to do this again next year, if not sooner. And with that, there are a couple of housekeeping things for the people listening, and that is that I need you to fill out your forms. So you need to turn in your sign-in sheets to the AAST office by this Friday, February 18th, and join us for the next grand rounds on Wednesday, the 23rd. Thank you, and have a great night. That's awesome. All right, see you guys.
Thank you.
Pleasure.
Bye, thanks.